Hi, everyone. I've got a very quick and exciting announcement here. We're hosting our very first ever in-person meetup on November 7th from 6 p.m. to 8 p.m. in Denver at the ASHG conference. It's going to be a fantastic opportunity for past guests, future guests, listeners, and friends of the show to come together, share ideas, and chat about all things genetics and precision medicine. We have reserved a very cool venue. We're going to have free food and drinks, and there's going to be a lot of interesting people in attendance. We're sharing this event first with listeners of the podcast as well as past guests. So if you can be there, please register as soon as possible because the spaces are limited. You can register at lu.ma/geneticspodASHG, all lowercase, no spaces or dashes in any of the words. The link to register is also in the show notes and it's easy to use on your phone. Again, that's lu.ma/geneticspodASHG, all lowercase. Mark your calendars, come say hi, and I can't wait to meet many of you in person. One of the challenges of podcasting is you often have absolutely no clue who the listeners are on the other end, except those of you who I really appreciate who drop me an email or say something on LinkedIn. But that's actually a very small minority of people. So if you can't make this meetup for any reason, but you really like the idea, then please don't hesitate to drop me an email at patrick@sonogenetics.com just to say hi. Let us know where you're based so we can keep it in mind for future meetups. And if people like this sort of thing, then we're going to plan to do more in the future. So thank you again, and we look forward to seeing you there. Hello and welcome to the Genetics Podcast. I'm your host, Patrick Short. My background is in population genomics and studying the genetic causes of rare disease. I did my PhD at the Sanger Institute in the University of Cambridge and have been in biotech since 2018 when I started Sonogenetics. Sonogenetics helps academic and industry researchers to run large-scale genetic testing programs that speed up their clinical trials, generate data sets for the next big breakthrough, and give participants the best possible experience taking part in research. Each episode of the Genetics Podcast, we bring you insights from the leading minds in genetics and precision medicine, including household names and Nobel Prize winners, as well as early career scientists and biotechs working on the next big breakthrough. Whether you're a scientist, entrepreneur, executive, patient advocate, or simply someone curious about how genetics shapes our world, you're in the right place. Thank you for listening, and let's get started. Hello, everyone. Welcome back to the Genetics Podcast. I'm really excited to be here today with Mark Taylor, who is the head of strategic partnerships at the NIHR in the UK. And he's also a person living with MS. So he brings a dual perspective to this of both being heavily involved in the research ecosystem in the UK for a big chunk of his career, and also has a great perspective as a patient himself, an advocate. I was speaking with Mark before this, and I share a similar perspective as I've mentioned on the podcast before. We have a genetic kidney disease that runs in the family. I've also been involved in population genetics research for pretty much my whole professional career. So I'm excited to explore the unique perspective that you have of being on both sides of that aisle today. So Mark, thank you for taking the time to be here with us.
Patrick, thank you for having me.
I would love if you could just give people an orientation of the NIHR as an institute or as an institution, and also the kinds of roles that you've played over the years to help set the scene.
Yep, no problem. So NIHR fund, enable, and deliver world-leading health and social care research that's aimed to improve people's health and well-being, but also to promote economic growth. The National Institute for Health and Care Research, to give its full title, is funded by the Department of Health and Social Care in England. It works in partnership with the National Health Service, universities, local government, other research funders, patients, and the public. And they're also a major funder of applied health research in low and middle income countries, work that is principally funded through the UK government international development funding.
And how about strategic partnerships is one of those things that often means I do lots of things, and I'm comfortable as a talented generalist dipping into this, that, and everything. What is strategic partnerships in your case? What are the kinds of things you focus on?
So NIHR is structured in quite an unusual way. The work is directed by the Chief Scientific Advisor at the Department of Health, which is where the Science Research and Evidence Directorate sits. And the Department of Health then contracts with a number of places to run coordinating centers that runs the day-to-day operations of NIHR. And I sit in one of those coordinating centers hosted by the Laboratory of the Government Chemist. So it's quite complicated structure. Because of that, it requires generalists like me to look at some of the issues around running research management on a broader scale. Strategic partnerships is often mistaken by some of my colleagues as something commercial, whereas it's much more of a broader view. A lot of what I do is looking at issues with the system that require getting a group of broader stakeholders together and look at some of the issues and potentially some of the solutions to some of those problems. So, for example, at the moment, I am working with the Health Innovation Wessex crew and a number of others to look at issues around adoption and implementation of early stage innovation within the UK health and social care system. Looking at some of the things that we've learned over the past few years, some of the problems with adoption and implementation, and coming up with ways of supporting small and medium-sized enterprises when it comes to developing their idea in a manner which will be more adoptable and implementable within the healthcare system itself. There's a lot of work that's been done on this in the past. Most of that work has been aimed at later stage innovation. So for your listeners who understand the NASA technology readiness level scale, a lot of the work supporting SMEs is technology readiness level 5, 6, or 7, past the prototyping, the black box stage. Whereas there is some evidence to suggest if you work with SMEs much earlier, the eureka stage, jumping out the bath, whiteboarding the idea up, getting some Lego bricks and coming up with the proof of concept, getting involved there, that they can help design in what's necessary to make it more likely that it will be usable at a later date if the innovation is successful. So strategic partnerships is working with people across the piece on a wicked problem like that, if I can use that terrible term. I'm also doing some work on faith-based research engagement. I think we learned over COVID that there were certain groups that weren't really interacting with the healthcare system, partly for historical reasons, partly because we are sometimes difficult to talk to. So I'm working with colleagues like the Centre for Research Equity in Oxford to look at ways of how we engage with faith-based groups. What are the enablers and barriers? So again, you can't do that on your own. It's creating that group, that set of stakeholders to actually look at a particular problem and see what the solutions might be. So strategic partnerships is very varied. And you're right. You can't be an expert at anything, which is very lucky because I'm not. I am a generalist, if I can use that terrible term.
I'd love to actually dig into both those areas a little bit because they're both really interesting to me. On accessing the NHS or taking some new innovation and helping have an impact on patients by bringing it to the health system, what are the common challenges that people run into there? And what are the things you're trying to work backwards from to make it a little bit easier and more successful?
Actually, this is going to sound like an odd thing. In conversation with a lot of SMEs over a number of years, one of the biggest problems is an unconscious bias that it's impossible. There are a number of stories where people have failed to get their idea into the system. And those stories are quite persuasive in making people think it is close to impossible or impossible. So there's that almost psychological barrier to get over, that it is possible that people do it. For SMEs, unsurprisingly, because they do lack resource, they are small companies. There isn't necessarily the resource to do the stakeholder engagement necessary. So, if you've spoken to a clinician and a couple of patients with condition A or condition B, that tends to be all the resource allows. And yet, that is rarely going to be enough. I mean, I take my experience with multiple sclerosis as a classic case. In the past, I have been asked about, would that be of interest as an MS patient, or would this be of interest as an MS patient? But I am hugely privileged. I live just outside of Oxford. I'm a white middle-class male. I know how the system works. Asking me what works for the broader MS community is I'm just the wrong person. So you need to have a broad outreach program to really understand what patients might need if you have this idea for a new device or diagnostic. And then there's the issue with the NHS itself in the sense of it's a very complex environment. If you have a new device of diagnostic, technically it may be brilliant. But if it is truly disruptive, then by definition, changing the way the NHS works for condition A or condition B or patient group A or patient group B isn't that simple. And there may be a cost of replacing an existing pathway with a new pathway, which is not necessarily taken into account, or if taken into account, not really understood properly. And there are more than just those two problems, but those are the ones that I think that seem to come up time and time again.
Yeah, there is that narrative that you mentioned is one I absolutely hear all the time. Whether it's medical device companies or digital health companies, they're often told by many people, go to the US and focus on that as your primary market. But yet, the NHS presents a very attractive market and an opportunity to get early feedback from a world-class system. How do people actually go about practically engaging on these kind of things? I think there's a misconception often that it's the NHS and it's one. You knock on a door and then they decide if it goes across the national system or not. In reality, it's much it's much more kind of federated in a way. Talk a little bit about that.
Yeah, I mean, it's interesting. There's a great paper by the Health Foundation called The Spread Challenge, which I sort of recommend to everyone to read because it's a nice paper that discusses the complexity of an innovation and the complexity of the pathway to get it into the system. So when it comes to drugs, then drugs are incredibly complicated. They take a long time to get developed, to be tested, but it is actually quite a known pathway. And therefore, actually, although the intervention, the drug is exceptionally complex, the pathway to get in is known. What the Health Foundation paper sort of says is that the simpler the innovation, the more complex the pathway to get it adopted and implemented. And I quite like that because I think that there is a point there. So if you've got something which is a new drug, fine, it's the Innovation Observatory or Horizon Scanning Centres is going to be called. NICE, MHRA, it's known. If you've got a device or diagnostic, it really depends on a number of things. Depending on whether it's going to be commissioned at a local or national scale, that's always an interesting debate. The sort of CE marking or the equivalent that needs to be done. The level of testing, if I can use that particular term, that needs to be done to be convinced what the value proposition is, a term that my colleagues at Health Innovation Wessex, Peter Rhodes and Frank Radcliffe are very eloquent talking about. I think the issue, though, with a lot of these things is, how can I put it? Where do you get help? So it is a complex system, the NHS. There is a lot of help out there, but you still have to find it. And I would suggest to any small company that the NHS Innovation Service, which is available on the web, you can actually sign up to that to flag yourself up as an SME that might require help.
Interesting.
The Health Innovation System, which I mentioned working with the Wessex Group, are a set of regional organisations which are there to help get things adopted and implemented into the system. Again, they're available. There'll be local and regional groups that will also be there looking to support. So there's a mosaic, if I can use that terrible term, of help and support on a local, regional and national basis. And NHS England also do a great job through their accelerated access scheme, through their procurement pathways. So there is help. It is a mosaic. It doesn't always appear, I think, to some SMEs as logical. But I keep going back to the fact that there is almost a mental barrier that's impossible. Whereas it's not impossible, it's just very, very difficult.
Right. Yeah.
Which is not lots of comfort, but
right. Yeah, that's some comfort. I think you made a really interesting point there around almost the more regulated something is, the clearer. It doesn't mean the path is easier, but it's very clear. So, I guess a couple of examples: the new sickle cell beta thalassemia treatment, Casgevy, or prior to that, Zolgensma for spinal muscular atrophy. These are breakthroughs, but that are regulated at the highest level. So they kind of go straight to the top, and the decision is made on a national scale. And obviously there's still layers to it. NICE needs to determine how much or whether they're willing to pay for it. And that's separate from an MHRA approval. But the path there is national scale and it's clear. Whereas if you have a new app for managing wait lists at GPs or a patient portal or something like that, that may be adopted on a trust by trust level, it tends to be much more of a bottom up motion rather than going, straight to someone at the top to say, hey, we've got this amazing and highly regulated breakthrough that you need to spread across.
Exactly that. And by definition, pharma also has the money and the patience to spend on the support required to go through what is a known system. So, once again, SMEs lack resource, and therefore the supporting mechanisms need to be there to give them the help they required. It's almost like funders providing Sherpas to get people across mountains in that sense.
Yeah.
Because it is quite mountainous, it is difficult, but there are successes. And especially if you get the patient engagement done properly, which is difficult, and people do shy away from it again, because when you think about it, SMEs are entrepreneurs and they are always selling. And I mean that in the most positive way. Every group of SME I've ever worked with, whether it's in this job or previous jobs that I've done in the past, which have similar bents, you talk to an SME about their innovation. And no matter what you're asking about it, they will always unconsciously swerve into selling why it's brilliant.
Right.
Whereas in many ways, to get that patient engagement right, there's a lot more listening that needs to be done. Better questions, being able to do a semi-structured interview set or run workshops to get that engagement, to get that feedback. And if you're always selling, that's quite a difficult thing to do. You're an SME, you're 2, 3, 5 people. You've got to talk to some business angels soon or a venture capitalist. You need that extra 2 million in, 5 million, 500,000, whatever. The technique of actually talking and engaging with patients isn't necessarily as straightforward as people think, especially when I go back to the point that people tend to default to, well, I'll speak to 1 or 2 articulate patients.
Yeah.
And they are just not representative. As I said, I am the least representative MSer you're ever going to meet. So I'm the last person on earth to actually ask about your device or diagnostic for MS people, because I'm just not the target audience.
Not representative. Yeah.
Yeah. So that's really key, I think, when it comes to getting things adopted and implemented in. And early innovation needs to have as much patient input as is affordable, appropriate, proportionate. But equally, there needs to be a lot more thought about NHS co-design. So what I mean by that is there's always, with SMEs, clinical co-design, because the idea may have been jointly developed with a clinician or allied health professional. NHS co-design is co-designing with the system itself. There's a health economic technique called cost-consequence analysis. It's quite crude in many ways for this particular purpose, but if you do it properly, it shows you where the cost of your innovation is, where the consequences are. When you put it into the system. And that can therefore highlight stakeholders in the system that you weren't previously aware of. And those stakeholders may be just as crucial as the clinician who says, let's use diagnostic A, to the patient group that says, I want diagnostic A. There may be another stakeholder group between those two, not necessarily procurement, but somebody else involved, whether it's the nursing staff or the pharmacists, or some form of management structure within or without the NHS. You need to take that into account when you are trying to plot how to get your system, your innovation into the system.
Yeah. One of the big misconceptions, or I'll ask you if it's a misconception or not, is it's around this, whether it's impossible to get into the NHS, is how things are actually paid for. I think there's also a narrative that in the UK, it's really hard to get innovations paid for because for whatever reason, the system, despite being cradle to grave and in theory, things that save money over somebody's lifetime are readily adoptable. In practice, people tend to struggle with that. What have you learned about the more commercial aspect of this?
So I colleagues at NHS England will be far more eloquent than I am on this. There has been a lot of work on procurement pathways, which NHS England have done to try and ease that particular pain. So for all the complaints about the NHS being difficult to sell to, it is a remarkably innovative organisation.
Yeah.
But by definition, it does take into its heart new techniques, new diagnostics, new devices, new drugs. It's just a process that has to be gone through. So a lot of the time, I think what happens is you get technically brilliant ideas that aren't necessarily, how can I put this? Technically brilliant, world-class research that isn't necessarily adaptable to patient need in the real world.
Yeah.
And under those circumstances, it's never going to fly. I mean, I think I was approached, I think it was before COVID, by an SME who I sort of quote this person without naming them, why won't anyone buy my world-class product?
Okay.
And yeah, I get the frustration there, but it might be world-class in the wrong way.
Yeah.
It might be technically brilliant, but it might not be the solution that people look for. Again, that's why it's worth talking to a broader group of patients and a broader group of people within the NHS rather than just your everyday clinician, if I can use that particular term. But I do recognize that for SMEs with minimal resources, that could be close to impossible. But that's why you have the Health Innovation Network, which NIHR and NHS England work together on. That's why there are special groups like, I think Medilink in Birmingham I've worked with before. They're very, very good. And they've been very helpful on this pilot that we're running at the moment in Birmingham. So there are places you can go for help. But my one piece of advice is to stop selling and start listening.
Yeah, that's great. Always good advice. I have some direct experience with this kind of code development as well. Really early on in our company's life at Sono, we did a co-development project with Genomics England that was funded by Innovate UK and in part by Genomics England. And we actually published a white paper that described the whole process. But we had workshops with patients, we had workshops with different research stakeholders, and this was in the early stages of developing a participant portal for the use in genetics research and rare disease genetics research in particular. And we really zeroed in on discussions with families, often parents of young children with rare diseases that were part of the very early 100,000 Genomes project. And it was really informative for us to take a step back from writing code and actually spend a lot of time with people to go through this process. So we found that to be really impactful early on. And I think the advice you give to people early on is really good, because you can get so far down the road and do so many things. And it's almost kind of product development 101 in some ways, but you've got to have that close connection to all the customers, not just the person who might be paying for it, but the person who's using it, the person who it might affect, as early as possible, right?
Yeah, I think so. And as I said, it is a resource implication for small companies that may not have many resources, but it's even more expensive to have to retrofit later on when you realize you've gone down the wrong direction, which is one of the reasons we're doing this pilot. I think over a couple of years, hopefully we will potentially see some behavior changes. I mean, the SMEs who have volunteered to join the pilot are absolutely brilliant. They're really engaged. We had our first day and a half session a couple of weeks ago. They were, how can I put it? They wanted to learn. They wanted to talk. They wanted to listen to each other, which is always a good sign as well. And because it's a pilot, they were completely up for the fact that we were going to learn as much from them as hopefully they were going to learn from us. Because the structure of this pilot that we've done is this mix of getting people to understand the regulatory affairs, intellectual property. That's the bog standard stuff. The clinical co-design, well, that's talked an awful lot, but also a lot more on what the processes are, as I said, building up the value proposition, looking at patient and public engagement and NHS co-design. And we don't know whether we've got the level of learning right. So as I said, we will learn as much from the SMEs as hopefully they will learn from us. And without trying to sound odd about it, we are hoping to see behavioral changes over the period of the course, which is being run over a 6-month period, but also for a year or two afterwards. So it's exciting times. I've been working on it with Health Innovation Wessex and colleagues at NHS England and the ABHI, the the Association for British Healthcare Industry for 2-3 years now. So it's been a long time getting it up and running.
I'd love to talk a little bit about the second big topic you mentioned, which is the faith-based organizations and engagement there. What have we learned about what the challenge is there, and then what are we learning about ways to better engage with underrepresented populations in research like this?
So NIHR's DNA, I know it's a cliche, so apologies, but NIHR's DNA has always been patient engagement, public engagement, from when it started in 2007 onwards. And it's always one of the reasons I'm so proud to work at NIHR, actually, because it's always taken seriously. And in each iteration of NIHR, every time it moves forward, it goes another step deeper. So if you go back to the millennium, a lot of patient engagement was literally the equivalent of bums on seats, so patients in beds for clinical trials. And through NIHR, it's completely evolved and developed, looking at co-production with patients and public. So not patronizing patients, or even just having them on some form of advisory board, but getting them actually involved in the research process itself. NIHR did, a couple of years ago, a really nice piece of work with a number of people to look at community engagement. Looking at certain areas of the country, certain communities that have been not ignored, that's the wrong particular term, but really hadn't been listened to. Not because they were hard to talk to, but we're actually quite difficult to talk to ourselves. So how do we make ourselves more available, more open? How do we listen to more communities? And that was a very nice piece of work that has fed upstairs and has begun to develop the strategy for patient engagement. But I was having a coffee with Trish Greenall from Oxford. She's in the Department of Primary Care there. She might be known to your listeners as one of the people who was very vocal during the COVID crisis about masks. I've known Trish for a number of years. We're having a coffee. And she was talking about some work she was doing with a Sikh temple in Birmingham, and asked me whether I would be interested to meet them and have a think about faith-based research engagement. I have to say that this really started from a coffee with Trish. I've been working with Trish's team and the Centre for Research Equity. And all we've done at the moment, and I have to caveat with all we've done because it's a slow process, is we've done some informal interviewing of 14, 15 different people of faiths up and down the country, just to get a broad idea of what they feel the enablers and barriers are and what their experience has been, if any, when it comes to engaging with research teams. I think what we've learned so far, none of it is rocket science or a shock, is that we have to be very careful about how we engage. We have to be careful we don't go in, get the data we want, and just disappear. Yeah. There has to be some thought about long-term relationships and the equity of those relationships as well. We need to take into account, again, all of this is very obvious, that for each faith-based group, there needs to be an individual approach. Because the intersection between faiths and class and ethnicity and geography and et cetera, means it's going to be quite a complex lens in that particular sense. So the next stage, which we're sort of kicking off over the next couple of months, is to go from the informal to the formal. We are identifying a few initial groups to talk to in Manchester, Birmingham, London, possibly Belfast, in which, based on an individual approach for each group, there'll be a mix of semi-structured interviews and workshops to learn what works and what doesn't for them, and hopefully to create some long-term relationships. So again, they don't feel, the man from the ministry came in, not heard from him or her for quite a while, which would, I think, backfire. But there are certain fascinating issues that have come across so far about what do we mean by leadership. Now, that might sound like an odd thing to say, but if we're trying to approach faith-based groups, that we want to talk to the leaders of those groups to start with, but what do we mean by that? So even little things like what leadership means in each particular group is going to be something we're going to have to think through very, very carefully.
Yeah, that's interesting. And it's important because it's such a big priority right now, especially in the genetics and precision medicine field, that pretty much every new population genomics program that is getting started, or the big ones that already exist, have high on their agenda that we need to make these programs representative. We need to find ways to engage a more diverse population because we know we haven't done a good job with this historically. But what I find is often missing in this is the details of how. Everyone has the intent, but when it comes to what are we actually going to do differently, there's a laundry list of, localization into languages. There's engagement like this to make sure people understand what value am I actually getting. There's trust building, but the details are often less clear than they should be of how are we actually going to achieve it.
Yeah, it is a difficult thing because I have to acknowledge I'm a white middle class atheist. So doing faith-based research again is something I need to think in terms of allyship, not leadership, from my point of view. And I'm very, very lucky because I'm working with, this is a Centre for Research Equity, Polly Kerr and Paula Ray in Oxford, but also Samira Ben Omar, who did a lot of the work on the community engagement work that NIHR did a couple of years ago. And Nora Akbar as well from the NIHR PPIE team and Twickenham Coordinating Centre. So, all of these things are partnerships. All of these things are building people together on a temporary basis and looking at particular problems, taking into account everyone's strengths and weaknesses, I think, when it comes to these things. But it's going to be a slow process. I'm not expecting us to come up with anything revolutionary. It's just a case of doing it step by step, having those quiet conversations and making sure that we build up long-term relationships without, how can I put it? Without promising things that we can't actually deliver.
Yeah. There's two programs I'm aware of in the UK that I'd really be interested in speaking with at some point, which are East London Genes and Health and Born in Bradford. Both of these programs have done, I think, really long-standing and exceptional work in building research programs that are very tightly tied into the community. So I think there's a lot to learn from the kind of work you're doing, but there's also a lot to learn from programs like this that have been running for a really long time and engaging closely with community and figuring out what do we actually need to do differently practically to, in genetics, where I'm most interested in what does it look like to, this is some of the most sensitive information you can collect, and it's really fundamental to people in so many ways. And so how do you have this deep engagement that builds that trust, that allows you to do research that makes sure we don't leave people behind, but also not have the kind of helicopter approach that you mentioned before, where you come in and get the data and leave, and then nobody really knows what's happened with it.
Yeah, I'm not aware of the East London one, but I spoke to the Born in Bradford people pre-COVID actually about another piece of work I was looking at, and they are very cool. I have to admit they've done a fabulous job.
Yeah, East London Genes and Health is. I'll see if I'm connected with somebody there that I can put you in touch with. But they enrolled around 100,000 people of Bangladeshi and Pakistani heritage in the London area, obviously, and they've published some amazing research as well. We've discussed some of it historically on this podcast, but you learn so much from widening the aperture of who's involved in research that it's just something that we've got to do.
Yeah, no, absolutely. As I said, it's something that NIHR has taken very seriously. You go back pre-NIHR, bums on beds, all the way now, as they put more and more effort, more and more understanding. It's not about ticking boxes. It's much more about this is how we make research relevant. More and more work. And every time you get something done, as I said, Samira's work on the community engagement, you then realize there's another group or area or something you discuss. And even if there was a finish point of this, the refresh that you have to do on a regular basis to stop it being administrative, to stop it being managerial, to always make it fresh. As I said, I think NIHR have always taken this very seriously and have always supported a lot of this sort of work. Not just when it comes to particular groups, but things like the James Lind Alliance and research prioritization. So there are some very interesting bits of work that have been done with or through that group over the years, getting researchers and patient groups together to better prioritize research, to try and get that sweet spot in that Venn diagram between that world-class interest and that patient need. They don't necessarily overlap fully. You might think they should, but they don't always. But there is an overlap, and if you have limited resource, that's where you want to aim it.
Yeah. There's another interesting NIHR project that is around the same theme, which is the D Cyphr Program. It stands for DNA, Children, Young People's Health Resource. And what I think is really, I'm sure you're very aware of this, but for our listeners, what is really interesting about it, so it's for kids age 0 to 15, but it's a population genomics program. It's not focused on severe pediatric diseases necessarily. It's focused on mental health and diabetes. And this has been, I think, a big gap in research simply because it's really hard to navigate the ethics of engaging with with children in this kind of research. And I think we have sort of on one end of the spectrum, it's really clear that parents with kids with severe rare diseases have an incredibly important role to play in research. Also, when you're over 18, then you can consent for yourself. But this is I think they've just done a really thoughtful job, again, on the engaging with people ahead of time and really thinking through, okay, how do we fill the gap that we know there is here, without just doing the thing that most other programs have done, which is if you're between 5 and 18 and don't have a kind of major issue right now, then you're just not eligible. So I really admire that program for being brave in a way and kind of going after this harder to reach group.
There's some really interesting work done by rare disease charities. So one of the lovely things about what I do is talking to a lot of other funders. But 8-9 years ago, I did a little, because I only work 3 to 4 days a week because of the MS, but I did a little work for a small rare disease charity, looking at their research strategy. And what I found fascinating about that was exactly that. Their patient engagement, by definition, was unique. And therefore, from their point of view, although they didn't have a lot of money, the research they funded, one of the reasons they funded research was not to find a cure, but I've got to get this quote right because it is about 8 years ago, to make sure that the condition had the respect it deserved within the healthcare system. It was to almost raise awareness.
Yeah.
The fact they were doing research and could publicize research was making sure that for that particular rare disease, that rare condition, there was more likely that if you went to your GP with it, he or she wouldn't say, well, I don't know anything about this. They may have heard something. So it's ironic that patient engagement doesn't necessarily show that obviously patients want a cure. I want a cure for MS, but there's a deeper and multi-level need from patients. It's more than just a diagnosis, if I can use that particular term. And through proper patient engagement across the piece, you can discover all sorts of things about patient cohorts that you weren't necessarily aware of, because why would you be? You don't live with that condition.
Yeah, you reminded me of an episode probably a year or so ago. So episode 124, we had the chief medical officer of a biotech company called Recode Therapeutics, John Matthews, and we've been working with them on a genetic testing program focused on a rare disease called PCD. And the website for the program is Think PCD, and it's the exact thing that you mentioned there. That one of the primary goals of the program is to encourage patients as well as healthcare providers that may be seeing someone who could have this disease but is undiagnosed or underdiagnosed to think PCD. And I think that there's a whole category of underdiagnosed rare diseases that fall in this category where actually in some cases there's 10 times as many people undiagnosed in the population compared to those who are diagnosed. So it's just such an important concept to surface and make and use research to make people more aware to think whatever rare disease it might be that's underdiagnosed.
Yeah, I think that's a fair point.
As we wrap up here, you've shared a lot of great perspective. If people want to follow your work, if they want to get in touch with you about any of these topics, what's the best way for them to reach you?
I'm not on any social media at all.
Good for you.
It took me a while to wean off. I have just moved everything onto LinkedIn. That's the one thing I've left on. So you'll find me on LinkedIn, Mark Andrew Taylor, I think.
Amazing.
Always happy to be contacted that way. It's probably the easiest way of doing it.
Perfect. Well, Mark, thank you. This was a lot of fun and I really learned a lot. I appreciate you joining us.
Not a problem. Really appreciate your time today. And I look forward to hearing the podcast and maybe meeting up one day in Cambridge for a cup of tea.
I cannot wait. I would love to.
Okay. Well, thanks for your time today.
You too. That wraps up this week's episode of the Genetics Podcast. I'd like to give a huge thank you to our guests for sharing their valuable insights and experience. And thank you as well to our listeners, as always, for tuning in. If you enjoyed today's talk, the number one thing I would really appreciate from you is if you could share it with a friend or colleague who you think would enjoy it as well. We would also really appreciate if you could subscribe to our show and give us a quick rate and review on Apple Podcasts, Spotify, or your favorite podcast platform. Both of these things help us become more visible when people search for genetics and precision medicine podcasts. And we're always eager to hear from you. Please reach out to us with any questions or feedback on social media. You can find Cynogenetics on Twitter, LinkedIn, or visit cynogenetics.com. Finally, a big thank you to the team behind the scenes who make all this possible, in particular, Amy Cousins and Sonia Shah, who produced the show, and James Pierce from Selective Frequencies, who handles the audio engineering. I'm Patrick Short, your host, and it's been a pleasure. Thank you, and we'll see you next time on the Genetics Podcast.